Mhm. Mhm. Can you see my presentation?
Yeah. Please start. Thank you.
Okay. Good afternoon, dear colleagues and members of the Presidium. My name is Lyaisan Andreeva. I am an assistant of the Department of Internal Disease of the Moscow State Medical University, named after the Kimov. My report today is devoted to the following topic: features of changes in central aortic pressure and arterial stiffness during the day in patients with arterial hypertension, depending on concomitant comorbid pathology. According to the latest epidemiological study of RF, the prevalence of hypertension has increased from 40 to 44% over the past 6 years. By 2025, the number of people suffering from elevated blood pressure is projected to increase to 1.5 billion. Arterial hypertension refers to key problems of the 21st century medicine. Hypertension is often asymptomatic or with mild clinical manifestation, leading to damage to target organs. In this regard, a crucial role in risk stratification belongs to identify subclinical lesion of target organs. At the same time, the total risk of cardiovascular complication is affected not only by the level of blood pressure, but also by the presence of associated pathology, as well as damage to target organs, including the vascular wall. Currently, pulse rate velocity more than 10 millimeters per second is approved as a marker of vascular wall damage and an independent cardiovascular risk factor. It is known that pulse rate velocity is subject to daily fluctuation, and therefore it is of interest to study its diurnal dynamics. It is known that arterial hypertension is associated with a progressive increase in arterial stiffness, which from the point of view of the theory in Nielsen is interpreted as previously vascular aging. Currently, there are 3 ways to determine vascular age. Based on the intermediate thickness of the common carotid artery using the transformed formula HOMA et al. And according to the method of De Agostino, using data from the Framingham study, taking into account gender, age, smoking status, the presence of diabetes, blood pressure, total cholesterol, and ADL cholesterol, using the recommendation of the European Society of Cardiology based on the 10-year risk of fatal cardiovascular events calculated on the SCORE scale. Prognostic value of central aortic pressure and is closely associated with arterial stiffness, still being discussed and requires further research. It is known that in young healthy individuals, the difference between brachial and central blood pressure can be more than 30 millimeters AD. It is due by pulse pressure amplification. With age, increases the stiffness of the central arteries and central aortic pressure becomes higher than at the periphery. It's due by phenomenon of the reflected wave. Thus, the central aortic pressure and its deforming load on the heart more realistically reflects the load on the left ventricle. In modern medicine, the study of comorbid conditions is of increasing interest since most diseases of different organs and systems often agree them is a coexistence of 2 and or more disease in one patient, pathogenetically and genetically interrelated. The most frequent combination of comorbid conditions is associated with cardiovascular pathology, including hypertension. Of great interest is the combination of arterial hypertension with overweight and the development of metabolic syndrome. It is proved that cardiometabolic disorders led to early and significant lesions of target organs. Insulin resistance led to the following changes: hyperglycemia, hyperinsulinemia, hypertension, dyslipidemia, reduced fibrinolytic activity, endothelial dysfunction, inflammatory markers of atherosclerosis, microalbuminuria. This increases the risk of developing cardiovascular disease. Thus, arterial hypertension association with metabolic syndrome is characterized by the elasticity of blood vessels decreasing faster than in characteristic of the age, inadequate sensitivity of blood vessels to changes in hemodynamic parameters. In recent years, there has been an increased interest in the study of cardiovascular diseases, one of which is arterial hypertension with presence of hypothyroidism. Hypothyroidism leads to conditions such as insulin resistance, dyslipidemia, hyperhomocystinemia, hypercoagulation, and increased reactive protein. These changes increase cardiovascular risk too. In this table, we show that difference between subclinical hypothyroidism and manifest hypothyroidism. A number of studies have noted endothelial dysfunction even at normal thyroid hormone levels and worsening as it increases. In our research, we assumed that the association of arterial hypertension with metabolic syndrome exacerbates the structural and functional changes in the cardiovascular system, worsens the arterial hypertension, especially parameters of the central aortic pressure and arterial stiffness that affect the cardiovascular prognosis. We our task to conduct a comprehensive analysis of the dynamics of central aortic pressure indicators during the day in person without cardiovascular pathology and its patient with essential arterial hypertension associated with metabolic syndrome and subclinical hypothyroidism. To conduct a comparative assessment of daily arterial stiffness indices, pulse, waist velocity, arterial stiffness index, reflected wave times, pulse time index of norm in healthy individuals and patients with essential arterial hypertension associated with metabolic syndrome and subclinical hypothyroidism. To clarify the correlation between the indicators of central hemodynamics and the values characterizing arterial stiffness in individuals with essential arterial hypertension associated with metabolic syndrome and subclinical hypothyroidism. To analyze the relationship between vascular age comorbidity index and arterial stiffness in comorbid patients with essential arterial hypertension associated with metabolic syndrome and subclinical hypothyroidism. Our researching inclusion men and women aged 30 to 65 years, the presence of hypertension, the presence of metabolic syndrome, the written consent for participation in the study, and the ability to follow the study protocol. With exclusion and not inclusion, such patients as pregnant and lactation women, mental illness, the presence of acute disease at the time of participation in other clinical studies at the time of recruitment, or a similar clinical study within the previous 3 months, the lack of informed consent, the inability to follow the study protocol, patients with symptomatic arterial hypertension, and the presence of associated clinical conditions. All the patients include 82 with hypertension, which amounted to 2 main groups, 33 patients with arterial hypertension, 49 patients with arterial hypertension and metabolic syndrome, and control group consists of 22 people, matched for age and sex. All the patients do routine search methods, urinalysis, general analysis of blood, biochemical analysis of blood, electrocardiogram. Measurement of the daily monitoring of the central aortic pressure and arterial stiffness was performed using the oscillometric device BPLAB was attempts with the analysis of the main parameters of the central aortic pressure, systolic, diastolic blood pressure, hemodynamic pressure, pulse pressure, index of augmentation, and amplification of pulse pressure, and the parameters of arterial stiffness, pulse wave velocity, arterial stiffness index, and TIN index. Vascular age was calculated using the score scale modified by De Agostino. The comorbid status and mortality prognosis of patient was assessed using the Charlson index according to a point system. The technique consists in a scoring system for assessing age and the presence of certain concomitant diseases, which are summed up in points corresponding to concomitant diseases, and 1 point is added for each decade of life when the patient exceeds the age of 40. In this table, we see that the patients of all study groups were comparable in age. In the group of arterial hypertension and subclinical hyperthyroidism, women predominated, unlike other groups. In groups of comorbid patients, body mass index and waist circumference were statistically significantly higher. There are also differences in the growth rates of patients in the studied groups, which will be taken into account in the statistical analysis of the data obtained. The studied groups were comparable in terms of the degree and duration of hypertension. According to laboratory analysis, we see statistically significant changes in lipid and carbohydrate metabolism in comorbid patient, this group of essential arterial hypertension with metabolic syndrome, and the group of arterial hypertension with subclinical hyperthyroidism. In addition, in the group of subclinical hyperthyroidism, the levels of the thyroid-stimulating hormone were significantly higher. In the studied groups of patients, including comorbid patients, there are differences in central aortic pressure during the day. Statistically significant differences were found between systolic and pulse blood pressure in the brachial artery and in the aorta, which corresponds to the literature data on this issue. The analysis of the average daily indicator of the central aortic pressure revealed statistically significantly higher indicators of systolic and diastolic pressure in the aorta, and statistically low augmentation index after adjusting for height in the study groups compared to the control group. This confirms the presence of arterial hypertension in the study groups. We made a correction for height since the the BP lab with a TENS device takes into account the length of the aorta, which is directly related to the height of the patient when calculating. Similar changes we found during the day and night hours in all studied groups. Systolic, diastolic blood pressure, pulse pressure, and index augmentation are higher than in control group. In group of in the group of comorbid patients, arterial hypertension with metabolic syndrome and arterial hypertension with subclinical hyperthyroidism, significantly lower rates of pulse wave amplifications were revealed compared to control group. Intergroup differences were also revealed between the arterial hypertension with metabolic syndrome and arterial hypertension groups in the average daily and nighttime parameters of pulse wave amplification. We see that in group of arterial hypertension with metabolic syndrome, the pathological daily profile non-zipper prevalence, and in group of arterial hypertension with subclinical hyperthyroidism, the pathological daily profiles non-zippers and night pickers significantly prevailed compared to the group of isolated essential arterial hypertension, which is associated with a high risk of cardiovascular risk complications. Analysis of arterial stiffness reveals statistically significantly higher values of pulse wave velocity in the study groups compared to the control group. Significantly higher rates of arterial stiffness were found in the group of comorbid patients. In all the studied groups, statistically significantly higher indices of the augmentation index were noted compared to the control group. In group of arterial hypertension with subclinical hypothyroidism, statistically significantly high indices of arterial rigidity index were revealed at night, compared with control group, a group of patients with isolated essential arterial hypertension and group of arterial hypertension with metabolic syndrome, which prognostically increase the risk of coronary heart disease. In our study, we've also studied a new indicator of arterial stiffness, pulse time index of norm. The pulse time index of norm is percentage expression of the time of day during which the pulse wave velocity value didn't exceed the threshold of the accepted norm, 10 millimeters per second. In all the studied groups, statistically significantly pulse time index were noted compared to the control group. Significantly higher rates of pulse time index were found in the comorbid patients, in groups of arterial hypertension with metabolic syndrome and in group of arterial hypertension with subclinical hypothyroidism. Vascular age indicators reflect the state of the vascular wall and depend on concomitant comorbid pathology. In group of essential arterial hypertension with metabolic syndrome, arterial hypertension with subclinical hypothyroidism, vascular age was statistically significantly higher compared to control group. And in group of arterial hypertension with subclinical hypothyroidism, vascular age was statistically significantly higher than chronological age. In this category of patients, a statistically significant noticeable direct correlation of vascular age with the comorbidity index was revealed. So conclusion, the analysis of daily indicators of central aortic pressure and arterial stiffness revealed the greatest pathological changes, indicating a deterioration in the elastic properties of atherus in the group of arterial hypertension and metabolic syndrome and arterial hypertension with subclinical hypertension groups. As the vascular age increases, the likelihood of developing cardiovascular complications increases, which is more pronounced in groups of comorbid patients, arterial hypertension with subclinical hypothyroidism and arterial hypertension with metabolic syndrome. The result of this work allows us to consider the prospect of using the indicator to assess the risk of developing and timely diagnosis of complications of hypertension, in particular in patients with comorbid pathology. Thanks. Any question?
Thank you, Dr. Andreeva. That was an excellent presentation. Hope the participants have learned and benefited by sharing your view. Does anyone have a question?